globulus. So basic physiology, we learned in the pituitary last lecture. TRH comes from the hypothalamus, and that TRH stimulates the thyroid stimulating hormone from the pituitary. So from the hypothalamus comes TRH. This affects the pituitary, anterior pituitary. Pituitary will release TSH, and this TSH will ultimately go and act on the gland, that is the follicular cells of the thyroid gland. Now, they also may be stimulated with some TSI that we will come to later. So there are certain antibodies, immunoglobulins, which are active in Graves' disease. Now, entire endocrinology is mostly based on negative feedback loops. So this pituitary TSH will go and act on the thyroid gland and produce T3 and T4, which are the active hormones. In return, this T3 and T4 will have a negative feedback influence on the pituitary. That is, they will ask pituitary not to produce more TSH. They will also have a negative influence on the hypothalamus and will stop the hypothalamus from producing more TRH. So this is the basic concept. Hypothalamus producing TRF or TRH, that is thyroid TSH releasing factor. Okay, so this is T stands for TSH, releasing factor or releasing hormone. This will act on the pituitary. Pituitary will release TSH, that is thyroid stimulating hormone. TSH will go and act on the thyroid gland to produce T3 and T4. This T3, T4 will have a negative influence on the pituitary and also have a negative influence on the hypothalamus. So these are negative feedback loops. So if T3, T4 are low, there is no negative inhibition. So TRH is high, TSH is also high. That is a condition of primary hypothyroidism. If T3, T4 are in the higher range, that is hyperthyroidism, the negative influence will be more. So the TSH will be low and TRH will also be low. That is primary hyperthyroidism. So now this T3 is the active hormone. This binds to the nuclear receptors. Now, how do the various hormones act? That we will have a separate class, but just for some understanding here, that all hormones have a different mechanism of action. Some of them will act on the cytoplasmic membrane. So they have receptors on the membrane. So they act on the cytoplasmic membrane. But the T3 hormone will cross the cytoplasmic membrane and reach the nucleus and will act on the nuclear receptors. So T3 binds to the nuclear receptors and T4 also binds and acts through the nuclear receptors, but T3 is the active form and it has a higher affinity as compared to T4. Now the thyroid peroxidase is the enzyme which is responsible for oxidation and organification of iodide, as well as coupling of the monoiodotyrosine and diiodotyrosine. This we will again revise. So TPO, that is thyroid peroxidase, this is the most important enzyme and this is the most rate limiting action also. So this is the most important enzyme which will help in the synthesis of thyroid hormones. Then there is coupling of the two DIT to give T4, that is thyroxine. 4-iodo tetra, 4 means tetra. So tetra-iodotyrosine is thyroxine and DIT and MIT combined to form, here D is double, M is mono, so 2 plus 1, 3. So they will give triiodothyronine, that is the thyronine form. Okay. So this is the applied pharmacology, that is propylthiouracil inhibits both thyroid peroxidase and 5-deiodinase, whereas methimazole, it inhibits only thyroid peroxidase. So I will just give you a brief revision of everything and then I will revise with you again, because I know this is the most important part and this is the most difficult part also. So once again, how the hormone is released. So from hypothalamus comes what? TRH. This TRH acts on the anterior pituitary to give what? TSH. This TSH will act on the thyroid follicular cells to release what? T3, T4. And they will go and act in the body, that is end organs or the effector organs. Now, thyroid stimulating immunoglobulins, this we will learn later. These are antibodies that also stimulate the thyroid directly to produce more T3 and T4. Somatostatin is a GH inhibitor, as we had learned in the last class, the pituitary class. So somatostatins, they have an inhibitory action on the anterior pituitary. So whenever we have a GH deficiency or whenever we have a defect with the somatostatin, that will also affect the TSH. So this is the physiology of how the thyroid hormone is released. Now come and just focus here on this diagram and remember 4 steps. What are the 4 steps? Okay, just remember this mnemonic. Too old, can't recall. Right? I am too old, can't recall. So first step is iodine trapping. So whatever iodine is present in the food, whatever iodine you eat, that iodine is absorbed and it is present in the blood. So this iodine is present in the blood. This iodine is trapped in the thyroid follicular cell. So this iodine is transported along with sodium. So there is sodium iodine symporter. Symporter means anything that goes together. So that is symport. So that is a symporter. So sodium iodine symporter is this is a sodium iodine symporter, and this takes inside both sodium as well as iodine. Okay. So this is the iodine which is present in the food we eat and it reaches the blood. The first step is iodine trapping. So trapping. So once the iodine is inside the thyroid follicular cell, this iodine undergoes oxidation. Okay, so this iodine is oxidized. So how does it happen? This iodine is converted into, it combines with another iodine molecule. So it forms iodide. So this is iodide formation. Okay, so this iodide is then, what happens then? Then it is oxidized with tyrosine. Tyrosine is the amino acid which is present inside the thyroglobulin. So this entire mechanism happens over a base. So thyroglobulin is the base over which this all happens. So this tyrosine combines with this iodide, and there is formation of oxidized iodine, that is oxidation of iodine, organification and oxidation. What is organification? So organification was, oxidation was 2 molecules of iodine combining to form iodide, and now this is organification of iodine. So iodine is combining with tyrosine amino acid, that is organification. So 1 molecule of iodine with tyrosine forms monoiodotyrosine. 2 molecules of iodine combining with tyrosine is forming what? Diiodotyrosine. So that is organification of iodine. This is the organification, the second step. So after organification of iodine, there is what? Can't recall. Coupling. C for coupling. So coupling means they will all combine together. So MIT can combine with another MIT to form DIT, or 2 DIT will combine to form a tetraiodine molecule, or MIT will combine with DIT to form triiodotyrosine. So there is coupling. This coupling reaction is happening here. Again, everything happens over the base of thyroglobulin. Then the last step of release, that is the hormones which are coupled. Now they are ready to be released in the circulation. So T4 and T3, they are released in the system. When they are released in the system, it is 75% is T4 and 25% is T3. Okay. Now they reach the periphery. This is the organ. They are in the peripheral tissue. So once they reach the peripheral tissue, there is conversion of T4 to T3. That is the active form. Which is the active form of thyroid hormone? It is T3. So the T4, but which hormone is released in a larger quantity from the gland? It is T4. But which hormone, which form is active? It is T3. So at the peripheral level, at the tissue level, This T4 is converted into T3 by the enzyme 5-deiodinase. So what happens? It is converted from T4 to T3, that is 5-deiodinase. So one iodine is removed and it forms T3, and this active form, this is the active form, and this T3 will act at the organs. Okay, are we clear so far? यहां तक समझ आया है बच्चों? या do I need to repeat anything? किसी को बोलना पड़ेगा भाई. You can unmute yourself and talk.
Understood, ma'am.
यहाँ तक क्लियर है? चलो आगे
Yes,
चलते हैं. Good, thank you. So from here we move. This is the mechanism. This is a very important question. Every theory paper will have this question. Write the steps of thyroid hormone synthesis. Then comes, what are the thyroid function tests? So how are the thyroid function tests done? So if you look at the physiology, the thyroid produces mainly T4, which is inactive, and small amount of T3, which is active. Now this T4 is the major product, but it is converted to T3 in the peripheral tissue by 5-deiodinase. Now this 85% of the T3 is formed from the peripheral conversion. Only 15% is coming directly from the gland. Now, drugs which inhibit the peripheral conversion of T4 to T3. Which are the drugs which will not allow this conversion? Most important you have to know is propylthiouracil. So PTU or propylthiouracil, this is the molecule you must have read in your second MBBS. This molecule inhibits the conversion of T4 to T3. This is inhibited. Also propranolol, also steroid, that is dexamethasone, high dose of iodine, and the radiographic contrast media. So any dye or any contrast media will also not allow this conversion. Now, how do you assess? Now, before we go to this table, I will give you a very simple method but there is a 9-square method. Okay. So this is a 9-square method. So this is the axis of say TSH, and this is the axis of say T4. If T4 is high, maximum, and TSH is also high, maximum. Okay. So अगर ये भी ज्यादा है और ये भी मैक्सिमम है, तो TSH भी ज्यादा है और T4 भी ज्यादा है, तो हम क्या डील कर रहे हैं? We are dealing with secondary hyperthyroidism. So this column is secondary hyperthyroidism. अगर T4 भी बिल्कुल कम है, मिनिमम है, और TSH भी बिल्कुल मिनिमम है, दोनों यहाँ पड़े हैं, तो TSH भी कम है. कहाँ है कम TSH? ये रहा. अगर TSH भी कम है और T4 भी कम है, then we are dealing with secondary hypothyroidism. That is because of pituitary defect. तो ये हो गया मेरा secondary hypo का कॉलम. अब अगर मेरा TSH बहुत हाई है लेकिन T4 फिर भी लो है, so I have a high TSH but a low T4. That is high TSH, sorry, a high TSH with a low T4. I am dealing with primary hypothyroidism. So this is my column of primary hypo. रिवर्स करते हैं. मेरा TSH बिल्कुल लो पड़ा है लेकिन मेरा T4 बहुत हाई है. ये वाला T4 तो बहुत हाई है लेकिन TSH बिल्कुल लो है, तो ये क्या हो गया? मेरा TSH मेरा बिल्कुल लो है लेकिन T4 मेरा हाई है. सो आई एम डीलिंग विथ प्राइमरी हाइपरथायरॉयडिज्म. तो मेरा ये कॉलम क्या हो गया? प्राइमरी हाइपर. ओके. नाउ अगर मेरा T4, T3, T4 तो मेरा नॉर्मल पड़ा है, बीच में पड़ा है, मिडिल पॉइंट पे, लेकिन TSH मेरा लोअर साइड पर है. अभी मेरा TSH ऊपर नहीं जा रहा है, TSH लो है. तो अगर मेरा TSH लो है और T4 नॉर्मल है, तो आई एम डीलिंग विथ सब क्लिनिकल हाइपर. यहाँ पे ये क्या हो गया मेरा कॉलम? सब क्लिनिकल हाइपर. सिमिलरली अगर मेरा T4 नॉर्मल रहता है लेकिन TSH मेरा हायर है, TSH इस एक्सेस पर है, so if my TSH is high with a normal T4, I am dealing with subclinical hypo. तो यह क्या हो गया मेरा कॉलम? subclinical hypo. ओके. अब ये मिडिल रो बच गई जिसमें सब नॉर्मल है. अगर ये भी नॉर्मल है और ये भी नॉर्मल है, ये परफेक्टली, ये भी मिडिल पॉइंट पर है, ये भी मिडिल पॉइंट पर है, तो ये तो हो गया हमारा यू थायराइड. ये नॉर्मल पेशेंट है मेरा, यू थायराइड हो गया, नॉर्मल थायराइड हो गया. अब अगर मेरा T4 तो लोअर साइड पर है लेकिन TSH नॉर्मल नहीं है, TSH TSH मिडिल पॉइंट पर है, नॉर्मल है, लेकिन T4 लो है। सिमिलरली रिवर्स कर देते हैं कि TSH तो नॉर्मल है लेकिन T4 हाई है। तो अगर इन दोनों में से कोई भी कंडीशन बच गई है तो दैट मीन्स हम क्या कर रहे हैं, सिक यू थायराइड सिंड्रोम, मतलब थायराइड का अपना कोई फॉल्ट नहीं है, किसी और ऑर्गन की वजह से थायराइड हॉर्मोन्स टेम्पररली इधर उधर शिफ्ट हो रहे हैं, राइट। अगर TSH ज्यादा है और T3 T4 नॉर्मल है तो सब क्लिनिकल हाइपो। अगर TSH ज्यादा है लेकिन T3 T4 नीचे है, लो है, तो प्राइमरी हाइपो। TSH लो है, T3 T4 भी सब लो है, तो सेकेंडरी हाइपो। TSH लो है, T3 T4 नॉर्मल है, तो सब क्लिनिकल हाइपर। अगर TSH लो है और T3 T4 हाई है तो प्राइमरी हाइपर। अगर TSH भी हाई है और सब कुछ हाई है तो सेकेंडरी हाइपर, राइट। So this is a very important and interesting topic. You should know. नहीं समझ आए तो इसको गेम, just like a game you play it again. So what are the basic tests? हम सबसे पहले क्या करते हैं? First golden test is TSH. सबसे पहले हम टेस्ट करते हैं TSH. Then you measure it with FT4 and FT3. That is free T4 and free T3. And what is free T3 and what is total T3? So you measure free T4 and measure free T3. That is more useful than total T4 and total T3. So what happens, ये जो हार्मोन रिलीज होते हैं तो रिलीज होके ऐसे हार्मोन्स अपने आप ब्लड में नहीं घूम सकते, इनके पास कैरियर्स होते हैं, दैट इज एल्ब्यूमिन। सो ये यूजुअली प्रोटीन बाउंड होते हैं, दैट इज एल्ब्यूमिन बाउंड होते हैं, लेकिन एट द सेम टाइम कुछ पोर्शन इनका फ्री घूमता है विदाउट, कुछ पोर्शन हमारा फ्री घूमता रहता है विदाउट बाइंडिंग। तो विदाउट बाइंडिंग जो घूमता रहता है उसको हम बोलते हैं फ्री। तो जब हम टोटल मेजर करते हैं, व्हेन यू मेजर टोटल, तो यू मेजर व्हाट, यू मेजर बोथ द बाउंड फॉर्म एज वेल एज द फ्री फॉर्म। ओके, तो अगर हमारी रिपोर्ट कह रही है टोटल T4, टोटल T4 का मतलब है बाउंड T4 भी होगा जो थायराइड बाइंडिंग ग्लोबुलिन से बंधा हुआ है, TBG से बंधा हुआ है, कोई ना कोई प्रोटीन से बंधा हुआ है, थायरोक्सिन बाइंडिंग ग्लोबुलिन, कुछ ना कुछ एल्बुमिन से बाउंड है और कुछ फ्री है। So whenever you measure a total T4 or you measure a total T3, you are measuring the bound form as well as the free form. लेकिन एक्टिव फॉर्म कौन सा है? एक्टिव फॉर्म तो वही है जो फ्रीली अवेलेबल है काम करने के लिए। द पोर्शन विच इज बाउंड इज नॉट एक्टिंग, वो तो सिर्फ बाउंड है, एग्जिस्ट करता है, बट इट इज नॉट वर्किंग। काम तो वही करेगा जो फ्री घूम रहा है। सो इट इज ऑलवेज इंपॉर्टेंट टू मेजर फ्री T4, फ्री T3 एंड TSH। अब क्यों ये डिफरेंस आता है? कई बार आप देखोगे कि टोटल तो बहुत हाई आ रहा है लेकिन जब हमने FT3 करवाया, FT4 करवाया तो वो नॉर्मल आया। वाई? बिकॉज द TBG राइजेस। तो अगर TBG बहुत हाई है तो ज्यादा हार्मोन बाउंड होगा, तो ज्यादा हार्मोन मेजर होगा, तो टोटल हार्मोन बहुत रेज्ड आएगा, बट दैट इज नॉट एक्टिव फॉर्म। एक्टिव फॉर्म इज ऑलवेज द फ्री T4 फॉर्म। और किस किस कंडीशंस में TBG बढ़ जाता है? मोस्ट इंपॉर्टेंट कंडीशन है, क्योंकि ये बहुत जानना जरूरी है। Why? Because it happens in pregnancy. During pregnancy, the thyroxine binding globulin is very high. As a result, total T4 या total T3 are very high, but they are not active. So, before jumping to treat, आप पेशेंट को ट्रीट करने से पहले प्रेगनेंसी में उसका फ्री T3 देख लो, फ्री T4 देख लो, अगर वो नॉर्मल है तो यू डोंट नीड टू ट्रीट। सिमिलरली अगर कोई विमेन ओरल कॉन्ट्रासेप्टिव्स पर है, OCP पर है, तो वो भी TBG बढ़ा देगा। तो OCPs पर अगर पेशेंट है तो भी थायरोक्सिन बाइंडिंग ग्लोबुलिन्स बढ़ जाएंगे। तो टोटल T4 T3 आर इंक्रीज्ड व्हेन TBG इज इंक्रीज्ड। If the TBG level changes, then FT3 FT4 levels are not affected. TBG किसमें बढ़ता है? प्रेगनेंसी में और ओरल कॉन्ट्रासेप्टिव्स में। TBG कम किस में हो जाएगा? कंडीशंस लाइक नेफ्रोटिक सिंड्रोम, कंडीशंस लाइक मैल न्यूट्रिशन, जिसमें भी टोटल प्रोटीन कम हो गया बॉडी का, एनी कंडीशन वेयर यू आर लूजिंग योर प्रोटीन लाइक नेफ्रोटिक सिंड्रोम, मैल न्यूट्रिशन, सर्टन ड्रग्स लाइक एंड्रोजन्स, कॉर्टिकोस्टेरॉइड्स, फेनिटोइन, chronic liver disease again because of decreased protein production, conditions like acromegaly. So these are the conditions जहां TBG कम हो जाएगा, तो आपका टोटल T4 और T3 आपको लो मिलेंगे, बट आपको लगेगा TSH तो नॉर्मल आ रहा है. व्हाई? बिकॉज दिस इज अ फॉल्स लो. FT3 FT4 नापेंगे, मेजर करेंगे तो वो नॉर्मल आएगा. बिकॉज FT3 FT4 आर नॉर्मल, the pituitary has a signaling that everything is normal, so TSH remains normal. Now there are certain important words that you should know. What is a Wolff-Chekhov effect and what is a Jod-Basedow effect? तो जब भी हम अगर पेशेंट को ओवरडोजिंग ऑफ आयोडीन दे दें, सपोज किसी रीजन से हमने पेशेंट को बहुत हाई डोज ऑफ आयोडीन दे दिया, तो वी नीड आयोडीन टू प्रोड्यूस हॉर्मोन्स, राइट? दिस वी जस्ट अंडरस्टूड, जस्ट रेड कि आयोडीन चाहिए. आयोडीन इज टेकन इनसाइड द थायराइड फॉलिकुलर ग्लैंड. उसका आयोडीन से आयोडाइड बनाएगा, वो आयोडाइड से उसका ऑर्गेनिफिकेशन करेगा आयोडोटायरोसिन में. आयोडोटायरोसिन से कपलिंग होगी, कपलिंग होके वो हार्मोन बनेगा, रिलीज होगा. तो थायराइड हार्मोन बेसिकली इज टायरोसिन प्लस आयोडीन. तो टायरोसिन अमाइनो एसिड प्लस आयोडीन. लेकिन अगर आपने बहुत हाई डोज ऑफ आयोडीन दे दिया फॉर अ वेरी स्मॉल पीरियड ऑल्सो, तो इट विल सडनली शट डाउन योर हार्मोन सिंथेसिस. उसके सारे साइट्स को वो ब्लॉक कर देगा. तो इसलिए आयोडीन के जितने भी साइट्स होंगे वो टायरोसिन से बाइंड ही नहीं हो पाएंगे, वो उसको ब्लॉक कर देगा. सो दैट इज नोन एज वुल्फ-चेकॉफ इफेक्ट. ओके, हाई डोज ऑफ आयोडीन inhibiting the synthesis of thyroid hormones is Wolff-Chekhov effect. अगर हम बहुत देर के लिए लो डोज ऑफ आयोडीन दे दें, अब धीरे 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 हम थोड़ा थोड़ा आयोडीन दिए जा रहे हैं, तो क्या होगा? धीरे धीरे दे रहे हैं तो बिकॉज वो उसका ब्लॉक नहीं होगा, हार्मोन सिंथेसिस बढ़ता जाएगा. सो पेशेंट हाइपर स्टेज में चला जाएगा बिकॉज ऑफ आयोडीन इंड्यूस्ड हाइपर. So it will increase the T4 synthesis, and this is known as Jod-Basedow effect. Okay. Now, what about the antibodies? अभी हमने पढ़ा था, मैंने आपसे कहा था I will tell you what are the antibodies. हमने पढ़ा पूरे थायराइड हार्मोन सिंथेसिस में आयोडीन अपटेक से लेकर ऑक्सीडेशन, ऑर्गेनिफिकेशन, कपलिंग और रिलीज, एक ही एंजाइम हर स्टेप को मॉडरेट करता है, और वो है थायराइड पेरोक्सीडेज. थायराइड पेरोक्सीडेज, अगर इस थायराइड पेरोक्सीडेज के अगेंस्ट एंटीबॉडीज बन जाएं जो इसको काम ही ना करने दें, तो कुछ भी नहीं होगा. सो क्या होगा? इफ यू हैव TPO एंटीबॉडीज, देन द पेशेंट विल हैव हाइपोथायरॉयडिज्म, and that is a condition known as Hashimoto's thyroiditis. Hashimoto's thyroiditis, which is an autoimmune condition with high dose of high levels of high titers of thyroid peroxidase antibodies, and these antibodies do not allow thyroid hormone synthesis. So that is Hashimoto's thyroiditis. Now what happens? This gland, thyroid gland, it acts under the influence of thyroid stimulating hormone, जो पिट्यूटरी से आ रहा है. यह तो हमने पढ़ा था, राइट? दिस वी जस्ट रेड कि हमने पिट्यूटरी से आ रहा है TSH, एंड दिस TSH गोज एंड स्टिमुलेट्स द थायराइड ग्लैंड. तो इसके पास, ग्लैंड के पास रिसेप्टर्स होंगे, तो TSH क्या करेगा? अपने रिसेप्टर से बाइंड करेगा, TSH रिसेप्टर्स. अब अगर हमारे पास कुछ ऐसी एंटीबॉडीज बन जाएं जो जाके इस रिसेप्टर पे बाइंड करें और इसको स्टिमुलेट कर दें बिना TSH के, तो इनको बोलेंगे TSH रिसेप्टर एंटीबॉडीज. TSH रिसेप्टर एंटीबॉडीज, या फिर शॉर्ट में बोलते हैं ट्रैब, TRAB, TSH रिसेप्टर एंटीबॉडीज, ट्रैब. ट्रैब एंटीबॉडीज जो बनती हैं, दे आर सीन इन ग्रेव्स डिजीज. तो ये इसको स्टिमुलेट कर देती है. इनको हम, एक और दूसरा टर्म होता है थायराइड स्टिमुलेटिंग इम्यूनोग्लोबुलिन्स, थायराइड स्टिमुलेटिंग इम्यूनोग्लोबुलिन्स भी बोलते हैं, दैट इज TSI भी बोलते हैं. ओके, सो ट्रैब, TSI, they are just the same words and they are used for the antibodies that go and stimulate the thyroid gland, and they are seen in Graves' disease. So they are the TSH receptor antibodies, the TRAB antibodies. Now these TRAB antibodies, so this is a thyroglobulin antibody. The thyroglobulin antibodies are also present, but initially we used to focus on these TPO and TMA, what we call the TMA and TGA. TMA and TGA. There were two types of antibodies seen in Hashimoto's. TMA and TPO are just the synonyms, thyroid peroxidase or thyroid microsomal antibodies. TGA is another thyroglobulin antibody that is against the thyroglobulin, which is the base or the backbone of the hormone synthesis, which is present in the colloid, And we can have antibodies against thyroglobulin also, and they're also seen in Hashimoto's thyroiditis. Then the TRAB antibodies, which we just talked. Now, this TRAB antibodies are mostly stimulating immunoglobulins, that is TSI, as I told you. But at times, they can be inhibitory also. So they can go and block the synthesis. So we call them thyroid binding inhibitory immunoglobulins. So they will block the TSH from binding to the receptors and will not allow the thyroid hormone synthesis, and that can result into hypothyroidism. But this is a very rare condition. Most common antibodies we check and are present are the TPO and the TRAB. TPO found in hypothyroidism, TRAB found in Graves' disease. Now, what is the percentage of this antibodies in the general population? So, presence of antibodies does not mean that you have disease. Presence of antibodies just mean that you have autoimmune profile. These antibodies may not be doing anything. So, in Graves' disease, you find that the TPO antibodies are present in 50 to 80% population. Thyroglobulin antibodies are present almost in 50 to 70%, and the TSH receptor antibodies are present in 95% of the 80 to 95% patients. In case of hypothyroidism, again, TPO antibodies are seen in 90 to 100%. Thyroglobulin antibodies are present in 90%. And again, the TSH receptor antibodies can be seen in some 10 to 20% population. Besides this, even there should be another column, that is in normal population with no thyroid disorder, these antibodies can be present. Even in the first degree relatives or second degree relatives, these antibodies can be present, and they are very benign antibodies. They may not be doing anything at times. Then comes the radioactive isotope scan. Now, this is another investigation. So, you have checked the thyroid hormones, TSH check kar liya, T3 check kar liya, FT3, FT4 check kar liya, antibodies check kar li. अब एक और investigation है, that is radioactive iodine uptake. Radioactive iodine uptake. So, radioactive iodines, so we have a lot of isotopes. Isotope 123, 125, 131. But these iodine isotopes are the investigation module or the research modules, but we don't use them clinically, because if you use iodine, you need to keep the patient with you for 24 hours. Clinically, we are using a isotope of iodine, that is 99 technetium pertechnate. 99 technetium pertechnetate is used clinically, and this is a radioactive isotope which is given to the patient injected IV. This is injected IV, and you can take there are gamma cameras, and those gamma cameras are used to take the pictures of the thyroid gland, and it gives the result within 2 hours. Okay, so this dye is injected IV, and after 2 hours, by the time the circulation, the blood takes this radioactive iodine to the gland, this radioactive technetium pertechnetate to the gland, the camera images are collected, and that result is released in 2 hours. So, which iodine uptake, which iodine scan? This is varies with the functional status. After 24 hours, a normal gland will take up to 30% of the iodine. It is used for determining the cause of hyperthyroidism. This scanning or this uptake is done in conditions of hyperthyroidism. Why? I will tell you. They are also used to detect retrosternal goiters. So sometimes the goiters, they are the thyroid gland, it enlarges and it reaches behind the sternum. So it grows behind the sternum, and to find out the retrosternal goiter, you need a technetium pertechnetate scan. Sometimes the gland can have ectopic positions, so like it can be present anywhere in the neck, may not be the exact location where it is supposed to be present. So there can be ectopic thyroid tissue. Then in cases of thyroid malignancies, there can be thyroid metastasis. So you can use a whole body CT scan, a whole body technetium scan is done to find out wherever the thyroid gland is present, and that will take up the radioiodine contrast. If you find that on doing this, sometimes you find that the gland has an area where the dye is not taken up. So when the dye is not taken up, we call it a cold nodule. And most of the cold nodules are malignant. Now, few of the neutral and no hot nodule will anytime be malignant. What is a hot nodule? In case of hyperthyroidism, we just read that we do a radioiodine scan. So if it is a Graves' disease will give you a complete both lobes and the isthmus completely hyperactive and the dye is taken up by the complete gland. So you will get a very hyperactive gland picture. That is Graves. Suppose the gland is normal and there is only one nodule which is very toxic, very, very, very hyperactive. There is only single nodule. So this is a hot nodule. It is functioning. Hot matlab bahut kaam kar rahi hai. It's overactive. So hot nodule is a toxic nodule. So this toxic nodule is never malignant. It cannot be cancer. Whereas a cold nodule is most likely, in 20% of the cases, cold nodules are malignant. And at times, the gland has a neutral position, no hot, no cold. It's a normal gland, but it can be malignant. Okay. So when we do a technetium scan, you can have three pictures. One is this. The entire gland is hyperactive. This is seen in Graves. This is a second where you can have a toxic nodule. The third picture can be, this is a normal gland and you can have multiple nodules. And they're all toxic. So that is known as multinodular toxic goiter or MNG, multinodular goiter toxic MNG. That is toxic MNG. Okay. Now, there can be a fourth condition where you find that the gland is normal. There is no uptake. There is no uptake. There's a complete clean picture. And still the patient is having a very high T3, T4. What is it? बताएगा कोई मुझे क्या होगा अगर ग्लैंड ने कुछ भी डाई नहीं लिया, अपटेक नहीं लिया, लेकिन क्लिनिकली द पेशेंट इज हाइपर एक्टिव, देयर इज हाइपरथायरॉयडिज्म. This condition is called thyroiditis. What it is called? It is called thyroiditis. Why it happens? In case of thyroiditis, it can be viral thyroiditis, it can be bacterial thyroiditis, or whatever the reason, the gland is inflamed. Just like any other gland, any other body part which is inflamed, there is inflammation, and the thyroid capsule is ruptured. तो आपके पास एक थैला है जिसमें बहुत सारा सामान भरा हुआ है, वो फट जाए तो क्या होगा? सारा सामान बिखर जाएगा, फैल जाएगा और थैला खाली हो जाएगा. तो अगर ये कैप्सूल फट जाए, रप्चर हो जाए, तो थायराइड हार्मोन जितने भी उसने बना के रखे थे वो सारे सिस्टम में ब्लड में बाहर आ जाएंगे. तो बहुत हाई लेवल ऑफ T3 T4 मिलेगा और पेशेंट को क्लिनिकल फीचर्स भी मिलेंगे T3 T4 के. लेकिन जब आप स्कैन करोगे तो आपको पता लगेगा कि थायराइड का हमारा थैला तो खाली हो गया, द बैग इज एम्प्टी. तो डाई नहीं लेगा, वो वहां पे खाली आएगा. सो दिस कंडीशन वेयर द radioactive iodine uptake is not taken, there is a clean picture or clear picture, is a condition of thyroiditis. That is, some infection, some inflammation has ruptured the thyroid capsule. Okay, तो हम जब यहाँ बात कर रहे हैं हाइपर एक्टिव होने के बच्चे, तो हम बात कर रहे हैं हार्मोन सिंथेसिस की. Okay, we are not talking of the cell proliferation. We are not talking of the cell activity, the mitotic activity of the cell. We are talking of the physiological hormone synthesis. So any malignant cell will not be capable of producing normal hormone synthesis. वो अपने में ही इतना busy होगा to proliferate and to produce more cells that it will not be capable of producing hormones. So जो भी टॉक्सिक नोड्यूल है ना, वो सिर्फ इतना हाइपर काम करने में लगी हुई है. So there is no mitotic activity or oncogenic activity of the cell per se. It is the enzymatic activity or the hormone activity which is hyper. ठीक है? So हाँ, so जो हॉट नोड्यूल होता है बच्चे, वो कभी भी मैलिग्नेंट नहीं होता. जबकि जो कोल्ड नोड्यूल पड़ा है, क्योंकि उसके पास काम ही नहीं है, कुछ काम नहीं कर रहा है, वो अपने सेल प्रोलिफरेशन में, माइटोसिस में, मियोसिस में, अपने माइटोटिक ऑन्कोजेनिक एक्टिविटी में इन्वॉल्व है. ठीक है, तो ये हमारी ये कोल्ड नोड्यूल, आपका जो पिक्चर्स आएंगे वैसे आएंगे. सो ये हॉट नोड्यूल आया, पूरा ग्लैंड नॉर्मल दिख रहा है, लेकिन ये हॉट नोड्यूल दिख रहा है. सो दिस इज अ टॉक्सिक नोड्यूल. ये पूरा ग्लैंड ही अपना हाइपर हो गया, दिस अ वार्म ग्लैंड, दिस अ ग्रेव्स ग्लैंड। यहाँ पे पूरा ग्लैंड आपका हाइपर एक्टिव है, लेकिन बीच में एक जोन पड़ा है जो खाली पड़ा है, दिस इज नॉट वर्किंग। तो ये मैलिग्नेंसी हो सकती है यहाँ पे। यहाँ पे दिस कैन बी, कोल्ड नोड्यूल्स विल बी मैलिग्नेंट। नॉर्मली हमें ग्लैंड पिक्चर ऐसे दिखती है that the uptake is just same as the submandibular gland। हम किससे कंपेयर करते हैं थायराइड ग्लैंड का अपटेक? सबमैंडिबुलर ग्लैंड से। अगर सबमैंडिबुलर ग्लैंड्स की और थायराइड ग्लैंड की पिक्चर सेम आ रही है, दैट मीन्स द ग्लैंड इज नॉर्मल। अगर सबमैंडिबुलर ग्लैंड के पास डाई नहीं पहुंचा, सारा ग्लैंड थायराइड, सारा डाई थायराइड ने ले लिया, तो दिस इज हाइपर एक्टिव ग्लैंड, दैट इज ग्रेव्स। यहाँ पे ये नोड्यूल्स, बहुत सारे एक्टिव नोड्यूल्स आ गए, दैट इज टॉक्सिक एमएनजी। एक सिंगल नोड्यूल एक्टिव है, दैट इज टॉक्सिक एडिनोमा। ठीक है, राइट? सो वी मूव फर्दर नाउ। What happens if there is thyrotoxicosis with no uptake? This is what we just talked. So it can be thyroiditis, इसको बोलते हैं dequervain's thyroiditis या फिर subacute thyroiditis, SAT. It is a SAT picture, subacute thyroiditis. It can be factitious hyperthyroid. Now factitious hyperthyroid is a condition जो आपको psychologically disturbed patients में मिल रही है या फिर accidentally मिल रही है। पेशेंट ने बहुत सारी थायराइड की गोलियां उठा के एक साथ खा ली, दैट बिकम्स थायरोटॉक्सिक। नाउ आपके पास एक वाइवा में बहुत इंपॉर्टेंट इंटरेस्टिंग क्वेश्चन आपसे एग्जामिनर पूछेगा, अगर पेशेंट के पास हाई T3 और हाई T4 है, ओके, सो आप क्या बोलोगे? थायरोटॉक्सिक बोलोगे या हाइपर थायरॉइड बोलोगे? सो व्हाट इज द डिफरेंस बिटवीन थायरोटॉक्सिक एंड व्हाट इज हाइपर थायरॉइड? कोई मुझे बता सकता है? एनीबॉडी? What is the difference between thyrotoxicosis and hyperthyroidism? This is one of the favorite question of every YY examiner. What is the difference between thyrotoxicosis and hyperthyroidism? So as the word explains, hyperthyroid matlab the gland itself is hyper functioning. So conditions like Graves, conditions like toxic MNG, or conditions like toxic single solitary nodule, toxic MNG, toxic solitary nodule, or Graves, they are hyperthyroid conditions because the gland thyroid is producing more hormones. Whereas any condition of raised hormone, clinically matching thyrotoxicosis, a picture of thyrotoxicosis, but the gland is naive, the gland is innocent, the thyroid gland is not the problem. So raised T3, T4, when they are not, the source is not a hyperactive gland, that is thyrotoxicosis. So it can be factitious, like patient ने बहुत सारी दवाइयां बाहर से खा ली, iatrogenic, sometimes doctor has prescribed a very high dose, so it can be iatrogenic. It can be patient overdosing by accident or by intention, so it can be factitious. Then it can be subacute thyroiditis, that is de Quervain's thyroiditis. At times, there can be ovaries which are producing more of the thyroid hormones. That is, struma ovariae is a condition. So, struma ovariae is a condition where the thyroid hormones are produced by the ovary, right? So, these are the conditions which will give you thyrotoxic clinical picture with a decreased radioactive iodine uptake. Sometimes you find a hypothyroid patient with increased uptake. Now, this is a reverse condition. You are finding a high uptake, but clinically your picture is showing a TSH very high and T3, T4 low. So a hypo patient with increased uptake. We just read what? Iodine deficiency. So in conditions where there is no iodine deficiency, the gland is so hungry that the moment it gets the radioactive iodine, it will take up the entire iodine. But clinically, the patient was not making hormones. So it was a clinically hypothyroid picture. Then, of course, you go for ultrasound. This ultrasound will give you a cystic nodule. If you have a nodule, you can have a differential, whether it is a solid nodule or it is a cystic nodule. So if it is a cystic nodule, you will need a sonography. But they are mostly benign. Again, cystic nodules are usually benign. Solid nodules can be malignant. So if there's a solitary large nodule or a dominant nodule, in MNG, finally we go for what? FNAC. So fine needle aspiration cytology. Fine needle aspiration cytology is performed, and we look for thyroid cancers. Thyroid cancers we will take in the next class, the Thursday class. So basic concepts about thyroid hormone action. Thyroid hormones act by increasing the sensitivity of the beta receptors to the epinephrine. That is why most of the features of thyrotoxicosis are the features of increased sympathetic activity. That is, features resemble pheochromocytoma. So features of pheo like tachycardia, palpitation, raise in blood pressure, sweating, increased appetite, polyphagia, you are more hungry, you go for your increased stool activity, weight loss. So these are all features of thyrotoxicosis. Coming to our LMRPs. LMRPs we just know are the USP of DBA. So we will talk about the last minute revision points. What did we do? Drugs which inhibit the peripheral conversions. Which were they? PTU, propylthiouracil, dexamethasone, iodine, and the contrast dye. Wolff-Chekhov effect was what? And George-Basedow effect was what? High dose of high dose of iodine in a burst therapy, short dose, short duration, no hormone synthesis, Wolff-Chekhov. George-Basedow effect, long duration of low dose iodine giving increased T3, T4, that is George-Basedow effect. Thyroid binding globulin increased in pregnancy and OCPs. Thyroid binding globulin decreased in hyperproteinemic conditions like nephrotic syndrome, cirrhosis, drugs like androgen corticosteroids, low T3 syndrome, low T4 syndromes. In sick U patients, all are reduced. Everything will be in the middle range. TRAB antibodies, two types. They can be stimulating as well as inhibiting. Thyrotoxicosis with reduced uptake, factitious or dequervains. Hypo with increased uptake, endemic hypothyroidism, that is iodine deficiency. So, who will answer this question? So quickly send me the answer. Which is the most specific eye sign of Graves' disease? Whether it is the Dalrymples, von Graeff's, Stielwags, Kocher's, or chemosis. So which is the most specific eye sign for Graves' disease? So coming to the basic concepts of thyrotoxicosis. So thyrotoxicosis is increased thyroid hormones may not be coming from the gland. Hyperthyroid, increased thyroid hormones coming from the gland. Graves, autoimmune condition due to increased thyroid stimulating immunoglobulins producing generalized entire gland producing more thyroid hormones. Thyrotoxicosis, condition of increased thyroid hormones. So there is thyroid, enlargement of the goiter, increased radioiodine uptake, hyperthyroid, extrathyroidal sources, patient may be euthyroid, there is no goiter and decreased uptake, like struma overi, factitious, and the dequervain thyroiditis. Graves, there will be hyperthyroidism, there will be ophthalmopathy and dermopathy. So Graves we will be just covering if possible. Then multinodular goiters, MNG, toxic MNG, and toxic benign nodule or toxic solitary nodules. So this is a MNG. Multinodular goiter may not be functional or may not be functional. We don't know, may or may not be functional. Coming to thyrotoxicosis, we just read excess thyroid hormones. Thyrotoxicosis associated with hyperthyroidism. Now, this is interesting. We are talking of thyrotoxicosis because of hyperthyroidism. That is primary, caused by diffuse toxic hyperplasia, that is Graves, toxic single nodule, or multinodular goiter. This condition is also known as Plummer disease. So you have to remember the name. It can come as a MCQ. Plummer disease is toxic MNG. Then a very rare condition is TSH secreting pituitary tumor. That pituitary is producing more of TSH, and that is why we are getting a lot of high T3, T4, which is a very, very rare condition, secondary hyperthyroidism. Thyrotoxicosis is not associated with hyper. We just read struma overi, factitious thyrotoxicosis. It can be subacute granulomatous thyroiditis. It can be subacute lymphocytic thyroiditis, which is a painless condition. Coming to Graves. So Graves is an autoimmune condition and it is a triad. It will also have eye signs. It will affect your eye, that is ophthalmopathy. It will also affect your skin. So there is dermopathy. So autoimmune hyperthyroidism and ophthalmopathy and dermopathy is Graves' disease. It is an autoimmune condition caused by stimulatory TSH receptor antibodies, which we also call TSI or thyroid binding immunoglobulins. These patients have HLA-B8-DR3 positive. So HLA-B8-DR3 is associated with Graves' disease. Now, when you talk of certain terms like pretibial myxedema, now this is a misnomer. Myxedema is a condition of hypothyroidism, but pretibial myxedema is a condition seen in Graves' disease. So the skin changes of Graves' disease, you will find in the front of the shin, in front of the shin in your leg, here you will find some edema. So there is pretibial edema. So in the olden times, it was when it was diagnosed, it was believed to be because of hypo, but later on it was found to be present in hyper. But the name was not changed, so it's a misnomer. Pretibial myxedema is a condition of skin seen in Graves' disease. Eye signs of ophthalmopathy can occur in Graves' disease. It can occur in Hashimoto's also, but skin changes or dermopathy, it is very, very specific for Graves' disease. So what are the various eye signs? Graves' disease, it's a hyperthyroidism, but all hyperthyroid are not Graves. This we just read. Now, it's an autoimmune condition, so it can be associated with other autoimmune conditions, mainly type 1, Addison's, vitiligo, celiac, myasthenia gravis. All these autoimmune conditions can coexist. So coming to a quick recall questions, again is a normal weight of the thyroid gland. हमने पढ़ा था, if you remember, first slide. What is the functioning unit of the thyroid gland? What does the thyroid gland store in colloid? Colloid में हमने क्या store कर रखा है? What stimulates the release of TSH from the pituitary? Pituitary पे किसके असर से TSH बाहर आता है? Which enzyme is responsible for the oxidation and organification of iodide? एक और नंबर भी है यहाँ पे 8383088439 किसी पे भी भेज दीजिए. और अगर आपको इस पूरी क्लास का लिंक चाहिए, पीडीएफ चाहिए, तो भी आप हमें भेज सकते हो. Okay. So hyperthyroidism, clinically, there will be a goiter, which is a diffuse thyroid enlargement. At times, the blood supply is so high in the hyper-functioning thyroid gland that if you place a stethoscope over the thyroid, you can hear a bruit. आप सबने कार्डियोलॉजी पोस्टिंग में ब्रूई सुनी है? Do you know how to appreciate a bruit? तो अगर आप अपना स्टेथ thyroid gland पे लगाएंगे, and if it is a Graves disease, you can hear a bruit over the gland. So that is known as Graves disease condition. Cardiorespiratory features, there will be tachycardia, palpitation, there can be atrial fibrillation, which is more commonly seen in elderly. There can be dancing carotids. Now, this is again very important feature. If you look at the carotids, you will find the carotids are dancing because of the increased cardiac output. Then there is increased pulse pressure. So all the features of increased cardiac output will be seen in the cardiovascular system. You will appreciate all the features of increased cardiac output. Then there will be soft systolic murmurs. Patient can precipitate angina. There can be high output cardiac failure even. So if it is an old patient, geriatric patient, you can also have cardiac failure. Some patients with thyrotoxicosis will develop a reversible diastolic dysfunction and a low output failure. So it is called thyrotoxic cardiomyopathy. There is a dilated cardiomyopathy. So sometimes what happens, it's a prolonged disease, it's persistently happening. So there is a cardiac failure, which is a low output failure or a thyrotoxic cardiomyopathy. Now, there is a Means-Lerman scratch. What is a Means-Lerman scratch? Means-Lerman scratch or a Means-Lerman sound, it's a scratchy sound which is heard over the precordium. If you place your stent over the precordium in a Graves disease, you will hear some scratch. It's a khachar khachar, aise rub karte na, jaise when you rub two papers, you hear some scratch. So that Means-Lerman scratch, it is a mid-systolic murmur, which is heard in the setting of hyperthyroidism at the left upper sternal border and at the end of expiration. Because जब आप end of expiration में when the heart is rubbed against the pericardium, it is because of, it is thought to occur from rubbing of the pericardium against the pleura in the high output hyperdynamic states of hyperthyroidism. and it is just similar to the pericardial friction rub, which is seen in pericarditis. Then there is Gram-Steele murmur, which is due to PR, pulmonary regurgitation. So these are some of the cardiovascular system examinations. We will revise all of these features with you in our cardiology classes. That what are the murmurs of PR, what is a Gram-Steele murmur, what is a mean Slurman scratch, and what are the features of pericardium or pericarditis. But these are, as of now, these are features of Graves' disease. In the GI, I already revised with you, there will be increased appetite, increased motion, and weight loss. So weight loss despite of normal or increased appetite. There is diarrhea. There is elementary glycosuria even. At times you can find that there is elementary glycosuria. So there is, in the neuromuscular, you will find what? Anxiety, tremors, irritability, nervousness in the outstretched hand. If you ask the patient to stretch out the hands, keeping all the fingers separated, you will find tremors. So nervousness, irritability, emotional liability. There is, patient is hyper, anxious, anxiety. Psychosis features, tremors. There are hyperreflexia. There can be hypokalemic periodic paralysis, that is proximal muscle weakness, and it usually occurs after the age of 25 and more common in males. Then there is bulbar myopathy. Now this is very interesting. Because of the bulbar myopathy, the eye muscles are affected, and because of the bulbar myopathy, there are eye signs. In the reproductive features, you will find amenorrhea or oligomenorrhea. Now, this is again very important. Hypothyroidism causes menorrhagia. Hyperthyroidism causes amenorrhea or oligomenorrhea. Then there is infertility. There can be spontaneous abortions. There is loss of libido and impotence in males. Ocular signs. Now, this is very interesting, and it's a huge list. If you have access to some of your clinical medicine books, there are a list of signs, more than 12, 20, 40, 20 signs maybe, but the most important ones are the upper lid retraction. So upper lid is retracted, that is known as Dalrymple sign. Then the white staring appearance, like a patient, you will find as if the patient is very angry. The white staring appearance is Kocher's sign. Then the lid, like if you ask the patient, if you normally look down, you will find that you can't see the upper limbus. अगर हम patient को किसी को बोलते हैं नीचे देखने के लिए, तो उसकी eyelid भी उसके साथ साथ नीचे आती है, आपको limbus नहीं दिखता है. Whereas in case of Graves' disease, the eyeball moves down, but the lid does not move, and you can see the sclera, the upper sclera you can see. That is the upper limbus, and that is lid leg with a down gaze. That is known as von Graffy's sign. The patient will stop blinking. The blinking frequency is decreased, and that is known as Stelweck sign. Okay, so there are certain eye signs. This is a very limited list. There are, if you go for MCQs, you will find there are more than 20 eye signs. So this is lid retraction. The lower eyelid margin normally rests at the inferior limbus. Retraction is suspected when sclera shows below the limbus. If you can see the sclera below the limbus, this is the Dalrymple sign, that is lid retraction in the primary gaze. Moderate bilateral symmetrical lid retraction, that is Dalrymple sign. This is sign. Now this is von Graffy's. If you ask the patient to look down, the upper eyelid lags behind, and the eyeball, as the patient is asked to look downward, and you can see the upper limbus. You can see the upper limbus. See? Can you see the upper limbus here? So that is the von Graffy's sign. Now this is the Geoffroy sign. That is absence of wrinkling on the forehead. You ask the patient to look upwards and there is wrinkling. But in this patient, you can see the wrinkling on the forehead is absent when the patient looks upwards with the face inclined downward. If you ask the patient to incline downward and look upwards, the forehead wrinkles. So this is Geoffroy sign. Now this is a bulging. This is proptosis. This is a proptosis. How do you measure a proptosis? You ask the patient to close the eyes and place your finger, your index finger, on in front of the eye, and normally the eyeball does not touch the finger. Your finger touches the forehead first and the cheekbone first. But if there's a proptosis, the finger does not touch the forehead or the cheekbone, it touches the eyeball. So if you touch the finger like this, you will find the eyeball. This eyeball, there is proptosis. This is the bulging eye or the proptosis. This is a diffuse hyperplastic goiter. So following the eye signs, they are seen only in Graves' disease, that is chemosis, exophthalmos. Following eye signs are seen only in Graves', that is chemosis, exophthalmos, corneal ulceration, ophthalmoplegia, papilloedema, and diplopia, which is typically when the patient looks up, and laterally inferior rectus is the earliest to get involved. Another MCQ, very important, the first muscle to get involved is your inferior rectus. So this is a specific chemosis, conjunctival chemosis is here. Dermat signs, again very important, there is palmar erythema. There is redness of the palms, spider nevi, loss of hair, alopecia, there is pigmentation or vitiligo, finger clubbing, that is thyroid acropathy. This is again very acropathy or acropathy, whatever you want to call it. This is again very, very important, a very typical sign of the Graves. Then pretibial myxedema, which is seen in over the dorsum of the leg and feet. This is again a misnomer, as I just told you. Area is well demarcated, raised, thickened, and maybe pruritic and hyperpigmented. Then there is separation of the nails from the nail bed, that is onycholysis. Separation of the nail from the nail bed. So these are the skin changes. This is your pretibial myxedema. This is a typical pretibial myxedema. You will find thyroid dermopathy over the lateral aspects of the shin. This is a very severe case, but normally this is what we see, the thyroid pretibial myxedema. And this is the acropathy. You will find clubbing of the nails. And there is, if you look at the X-ray, there will be soft tissue swelling. Other features, there will be heat intolerance, there will be sweating, gynecomastia, lymphadenopathy, hypercalcemia. Now, there is something called apathetic hyperthyroid, which is seen in elderly population. So because of the thyrotoxicosis happening in the very old age, these patients are very marasmic, cachexic, and they come with atrial fibrillation and weight loss. Most of the other features may not be appreciated, so they come with weight loss and AF. Now, this is a toxic adenoma causing hyperthyroidism. You can see the single nodule here. The patient had a partial thyroidectomy 20 years ago, and now he's coming with a toxic nodule. So this is a toxic nodule. You go for a scanning, 99 technician per technitate scanning is done, and a nodule is appreciated. How do you evaluate? Go for TSH, T4, T3 first, and you will find a low TSH, and you go for the 9-box method. A low TSH, but a high T3, T4. So this column is what? Our primary hyper. So there is low TSH and T3, T4 raised. Thyroid scan is done, giving us adenoma or MNG or a Graves. Hypercalcemia can be seen, but that is not a primary diagnosis. So non-specific lab tests, so raised serum enzymes, OTPT will be raised, GGT will be raised, ALP will be raised from the liver and bones. Bilirubin can be raised and hypercalcemia can be present. But these are not very specific to thyrotoxicosis. Specific are raised T3, T4 and low TSH and a radioiodine scan. Glycosuria, also known as the lag storage, because of the rapid absorption of the sugars from the GIT, because of the increased GI motility, this leads to transient hyperglycemia and glycosuria. So that is elementary glycosuria. Quickly revising the last minute revision points and then closing the class for today. Hyperthyroidism can be because of Graves, toxic nodule, or toxic MNG. Increased uptake with normal thyroid because of struma overi, factitious thyrotoxicosis, or de Quervain's thyroiditis. Graves' disease, autoimmune condition, features of triad of ophtho-dermo and autoimmune hyperthyroidism. Associated with HLA, B8, DR3. It will have cardiorespiratory features, GI features, and neuromuscular features. It can also have reproductive features, ocular features are present, and eye signs are actually staged by the mnemonic no specs. And you will tell me in next class what is the mnemonic no specs, no signs, only symptoms, only signs, proptosis, chemosis. So there's a mnemonic there for no specs. So eye signs are seen in all cases of Graves. There is a white sparing appearance, upper lid retraction, lid lag, that is von Graffi's, Dalrymple's, decreased blinking, that is Stellweg's, Geoffroy's. Eye signs. So there is no sign, only chemosis, exophthalmos, corneal ulceration, ophthalmoplegia, papilloedema, diplopia. Dermat, thyroid acropathy, that is finger clubbing, pretibial myxedema, onycholysis, heat intolerance, and hypercalcemia. Apathetic hyperthyroid seen in elderly population with AF, no non-specific lab features. There will be mild hypercalcemia. There will be elementary glycosuria. Now the treatment part. The treatment is, of course, drugs, beta blockers are given for symptomatic improvement. That is, propranolol is given, 20 mg BD, but it will not help in treating the underlying cause. It is only given for rapid control of symptoms. The mainstay of treatment is anti-thyroid medication that you must have read in your second year MBBS, anti-thyroid medication, that is carbimazole and propylthiouracil. Thionamides, they are both put together, they are known as thionamides. So carbimazole, that is methimazole, and which crosses placenta. Propylthiouracil, it will not cause the placenta, so it is safe in pregnancy. It will also prevent the peripheral conversion of T4 to T3. So this is the drug of choice in early pregnancy. Drug of choice in pregnancy. It will also inhibit the peripheral conversion. Skin rashes, agranulocytosis, and SLE-like features, hepatitis, they are the side effects, and they can happen with all anti-thyroid drugs. We will stop here. And for the remaining lecture, you can write to us. We will send you. For more details, you can go to this book, Medicine Simplified, Minnie Harrison. It is available at Amazon and Flipkart. I will be taking your lectures, live classes every Tuesday, Thursday, same time, 8 to 9. Next Thursday, 20th November, we will be talking about thyroid part 2. We will begin with hypothyroid, go up to thyroiditis and cancers. And please send us your answers so that we can give you some prize, maybe some benefit. Okay. Pituitary we covered. Today we covered thyroid part 1. Next class, thyroid part 2. Next week, we will take up adrenals, then parathyroids, then 4 classes of diabetes. And if anything remains, we will take up on the last 23rd of the December. And then January, we will begin with GIT. Okay, so stay connected. And if you want anything to change, let me know. I will try to improve on my teaching, on my method of teaching. Maybe I can go a bit slow, but actually the lectures are long and I have less time and I want to give you everything I know. So that's the reason maybe I'm a bit fast. Please ask all your friends to stay connected. I'd love to have students. More students will be there, so I will feel more motivated to teach. You can download the app. These lectures, my lectures are free. They're available on YouTube. You can have Sir's lectures also. Sir has a different pattern of teaching. He will teach you in a more thorough manner. He's a grandmaster. For any queries, please write to us. Any of these numbers. You can drop a mail. We will come back to you in 24 hours. That's it. Thank you so much, guys.